surname, Chris? Then I'd just like to introduce you all to this session and to welcome you to a joint session between the Society of Occupational Medicine and the Royal College of Psychiatrists. This webinar, I'm hoping, will be really useful. I'm looking forward to it. And I'm particularly pleased that we're working with the Royal College of Psychiatrists, but to have such a varied number of people both accessing it and also presenting. The webinar is of particular relevance to occupational psychiatrists, occupational physicians, occupational physician trainees, and occupational and organisational psychologists. However, I feel that our reach should not just be limited to those professionals, so I'm very pleased that the RC, Psych and SOM have opened it up to lots of different practitioners, because it will be of equal relevance to occupational health nurses, occupational therapists, physiotherapists and vocational rehab professionals. In short, all healthcare staff working in the workplace, but also it would be quite nice if we had some people with an HR background. I would like to ask all of the participants to set your microphone to mute unless you're speaking. It just stops that background noise. I'd like to introduce the three speakers we have this afternoon. Actually, it's four now. Professor Neil Greenberg is a consultant occupational and forensic psychiatrist. He's a trustee of SOM, so we're really grateful that he takes such an active part. He holds an academic post.
Turn it down.
You go.
He holds an academic post at King's College London, where he's currently Professor of Defence Mental Health. We're fortunate to have Neil as a trustee, and he's been doing quite a lot with us on webinars and helping us to produce some tools. His presentation will consider the return to work following mental health episode and the psychiatric aspects of return to work. Our second speaker is Dr. Reema Kibreab. She's a vocational rehabilitation specialist. I probably said it wrong, I'm really sorry. I'm dyslexic, so sometimes when I read something it doesn't quite come out right, so I apologise if I pronounced it incorrectly. And she
you pronounced it perfectly. I'm so sorry to interrupt. I'm not a doctor. This in the email that
you're a vocational rehabilitation specialist. I've had my spies out to tell me what your background is. So I'm really pleased that we've got a medical professional who's a psychiatrist, we've got vocational rehab, and we've got an organisational psychologist. So what a fantastic array of knowledge and skills, which will make a really valuable presentation. So I've mentioned about Reema, who will be doing a joint presentation with her colleague, Chris Browne. Our third speaker is Roxane Gervais. Roxane has done an awful lot with us for SOM. She's a chartered occupational psychologist. She's contributed to so many projects, I can't name them all, but it's included things like a toolkit, which has been accredited by the Royal College of Psychiatrists. And she developed the SOM Return to Work toolkit, which is available on the SOM website. And I'd urge all of you to have a look at that. Neil and myself were part of the team that developed it, but you were the leader. So you took a lot of the responsibility of getting it done to time, for which I applaud you. Thank you. There'll be a short period of time after each presenter has presented for direct questions that may well be in your mind, but please use the chat box facility to post any cues. If you've got any further cues that come up as the presentations progress, I've allocated a short period of time at the end of the afternoon to take those questions. So let's start off then. And the first presenter is Professor Neil Greenberg. Thank you very much. He's going to be talking about returning to work following a mental health episode. Over to you, Neil.
Thank you very much indeed, and I'll just find my presentation, which hopefully is there. Yes, excellent. So thanks very much indeed for asking me to speak. And I chair the Royal College's Occupational Psychiatry Special Interest Group. So hopefully there's a few occupational psychiatrists out there, and that's sort of my bio. I served in the military for a number of years. I manage a company called March on Stress. I do lots of different sorts of consultancy work with different organisations. See quite a number of occupational health, mental health patients, I should say. That's my Twitter handle. If you're interested in papers, then we try and pump them out quite regularly. We had a good push this week. On Wednesday, we had a paper come out in Occupational Medicine looking at the psychological impact of COVID on intensive care staff, which has been very well received, which is good news. Obviously, important topic at this time too. So what I'm going to hopefully do over the next 20 or so minutes is to give you some evidence, but also try and leave with a sort of a concept of a few ideas about how to sort of handle return to work from a mental health point of view. Now, we know workplace stress is a big topic. I don't need to tell you that. In terms of data on workplace stress, and this is from a labour force survey, as you can see over the years here how the rates per thousand, and this is self-reported importantly, has sort of varied. But with the eye of faith, and this is obviously pre-COVID, you can see. Oh, can anyone who's not on mute? Can anyone who's not on mute please put your microphone on? Turn your microphone off. That's great. So you can see over time with the eye of faith that there's been a sort of a gentle increase here in the workplace stress. And I imagine if we look at what happened last year, we would find that probably has increased as well. Many of you may have heard of the Adult Psychiatric Morbidity Study. This is a study done in England. It's done every 7 years. 2014 was the last one. I'm not sure whether actually one will happen this year. And this is the best data we have of mental health status in the UK, really. And the reason is that this is done by a person-to-person interview rather than just self-report. And so you can see here that at any one time, common mental disorder symptoms, about 1 in 6 overall, and slightly more common in women than men. The perhaps more important thing than just have people got mental health symptoms is about significant mental ill health. And so this is using something called the CISR, which is a clinical interval schedule revised. It's a proper good clinical tool that is administered as part of the APMS. And this really tells us about people who have got good going mental health problems, problems that very much at work would be likely to have an impact. And what you can see here is year on year, that also has increased. And that is a substantial increase, which is not self-reported. And so one of the questions I often get asked is stress more common and people just reporting it more? I think this shows us actually the underlying trend is definitely for an increase in rates of poor mental health, but it's a gentle increase. It's not a ticking time bomb. In terms of organisations, it appears that being part of a bigger organisation appears to be more stressful. And you can see here the sort of differences here, the overall and the larger workplaces, which obviously doesn't necessarily bode well for the NHS, which is probably the UK's biggest employer with 1.4 million staff. And the other thing I think is interesting in terms of self-reported stress is about who gets affected. And what this sort of graphic shows is actually it's professionals who tend to report the highest amount of stress. And I think it's quite interesting sort of looking here at different groups, but it's professionals, who seem to be sort of overall having the most challenging time. This comes as an old from Dame Carol Black's excellent report in 2008. And this, I think I like this because you can see from my haircut, hair and beauty are two topics I know very little about. But what this does show is that if you're looking at mental ill health, that actually hair and beauty workers don't appear to suffer with any particular sort of level of that. And what that tells you is that, without going into the detail, is that if you look across the different occupations, that mental ill health is not equally distributed. Presenteeism, obviously a really important topic, coming to work in body but not in mind. And as you probably know, presenteeism costs far more to the UK economy than absenteeism. So this talk that I'm giving is about return to work, but I think equally as important is return to function. And if you can spot someone's at work in body but not in mind, getting them back to full function is also important. And just occasionally, stories come up where, because someone has not been paying proper attention to work, that actually some very bad outcomes occur. And if you're looking at safety critical work, then obviously mental health and presenteeism can have some drastic outcomes at times. I thought this graphic's useful. I think it reminds us that this is looking at long-term mental health conditions and what the impact is of actually having a job. And what this shows us is that over time, if you have no long-term mental health conditions at all, compared to people who do, it doubles your chance of not having a job. So the difficulty with having a long-term mental health condition is not just that it stops you from working; it also means you become unemployed, and that is particularly problematic, particularly in the current climate. So in terms of again, someone's got their microphone back on, so if you could put yourself back on mute, that would be great. In terms of what causes stress at work, you've got obviously things to do with work pressures. Many occupations have got trauma as a predictable exposure, particularly if you're looking at emergency services, healthcare, social care, military, actually journalists, train drivers. There's a whole range where trauma is a reasonably common part of day-to-day work. But we can't forget that what goes on at home is also really important. And actually these three things interrelate. And certainly in organizations that I do some consulting with, one of the challenges is that many of them say, well, this home front stuff is not really our responsibility. And to some degree they're right, but it still affects people's mental health and it still affects their ability to do their job, which is important. So what are the common mental health disorders that we see in the workplace? There's some of them I'll just run through. And anxiety is a disorder when it's more than normal anxiety. I mean, many of us, and if you look at the national data, are feeling more anxious than normal now, probably completely understandable in the middle of a pandemic. If it interferes with function, it lasts for days rather than weeks. And there's lots of different types of anxiety disorders out there. I'm not going to go through them all. But they have severe symptoms. They can often manifest or appear to manifest as physical health problems. And although this seems like a funny thing to say, they can seem to be infectious, not in a COVID way. But if you ever work in an organization where people are particularly anxious, then actually doesn't just affect you. Can you check this? I'm doing it a few times. Is it right? It can definitely have an impact upon colleagues. Depression is a disorder when it lasts for more than 2 weeks, when it affects your function. At the moment on ICD-10, the three key symptoms are low mood, tiredness, and lack of enjoyment. ICD-11 is going to remove their tiredness as a key symptom, and it's going to be lack of enjoyment and low mood are going to be the key symptoms. And of course, this is important because of the risk with self-harm, particularly when people are hopeless and also when they're misusing substances, particularly alcohol. So within a workplace, thankfully, completed suicide is rare, but when it happens, it causes, understandably, a huge amount of grief for everybody. These are very common adjustment disorders. So in the military, which I've got a lot of experience of, this is the most common disorder seen in the military, by military mental health professionals. We've all had adjustment disorders. A girlfriend's left us, we've lost a job, you've not got a promotion when you think you should have done. You have short-term, usually short-lived disturbance of emotions, thoughts, and behavior, impairs your function. And it represents the extreme end of the normal spectrum of responses to trauma. And once the stressor goes away, actually anxiety adjustment disorders tend to improve. But the important thing here is that in many workplaces, if your adjustment disorders because you believe your boss is mistreating you or harassing you, or if you've got a grievance process against you, that stressor can often go on for a long time. And therefore people can stay in this adjustment disorder sort of state for a long time. And although these are often described as a mild disorder or a relatively non-serious disorder, actually the range of difficulties it can cause can be really huge. And the key thing is that people who have adjustment disorder may well act out of character. And that might be by being a bit more shouty, it might be by not being effective at work. But in extreme cases, I do forensic things as well, it can lead to people committing serious criminal acts, as well as just being upset. So it's wrong to think of adjustment disorders as things you should ignore. because what they do need is absolutely to be well managed. Trauma happens as well. This is the Diagnostic and Statistical Manual, DSM-5's definition of a traumatic event. But the reason I put this up rather than go through all the different bits of it is to show here that actually DSM-5 recognises that there are groups of people who have frequent exposure to trauma as part of their job in the course of professional duties. And if you speak to a police officer, as I have done many times, who might have PTSD, and you say, so which one of those incidents do you think it was that caused your problem? They might often sigh and say, do you know what, I just don't know which one, there's just been so many. And so sometimes it's not possible to tie your PTSD to a particular incident. And certainly if you're speaking at the moment, with intensive care staff, or indeed other healthcare professionals, some of them might say, the whole last year has just been a whole stream of unpleasant and traumatic experiences. So the type 1 trauma, which is the big kind of explosion, the dog bite, the assault, that's when someone functions reasonably well and they stop functioning. It's this type 2 trauma, this chronic exposure, that is the most difficult to spot, because what you see is this final straw thing. You see Bob the Builder, who's normally a happy-go-lucky person. You see Bob being a bit shouty at work when you move his chair, and you think, that's really strange, that's really out of character, that's not what Bob's normally like. Well, the reason that Bob's not their normal self is the fact they've been going downhill for a while now. And every time someone said to Bob, how you doing? Bob goes, oh, I'm fine. And they go, oh, that's good. Again, someone's put their microphone on, so if they could turn that off, that'd be great. And over time, Bob's gone downhill, and then something small sparks them off. So what's really important is being able to spot people on this sort of downward stage. I'm not going to spend a long time talking about stigma. You know what stigma is. I hope it's about knowledge, attitudes, and behaviour. It causes problems. But the reason I just want to mention it briefly, then this is a detailed study that I won't go into a lot of detail, but we interviewed over 60 veterans with mental health problems in a lot of detail to work out pathways towards getting care. And as well as stigma, fears about what people think of you affecting, there's a whole lot of reasons people don't get care, is they don't know they have a problem. That's a mental health problem. They don't think they deserve it. They don't think treatment will help. But importantly, from a healthcare point of view and getting people back to work, there is this piece here where if you go and you get care, and actually the care you get doesn't really fit with what you need or doesn't fit with what you think you need, then actually people drop out of care, and therefore they don't manage to get the benefit and don't get back to work. And then it's really difficult to get them back in. So that first time that you give someone some assistance when they do have mental health difficulties, it's really important that you engage with them in a way that addresses the fact that they may not want to come back, and that they're afraid that they're going to get labelled. And so you need to be aware of that and actually actively address it in treatment. Otherwise, they just tend to drop out. So I'm going to give you just a bit of background on some of the evidence of return to work. So there's a number of studies that you can find out there which have looked at predicting return to work, what affects it. So this is quite a good one. It's a little bit old now. And this finds that primarily one of the things that predicts the most is how severe is the problem you've got, which isn't surprising. How long it's gone on for before someone takes sick leave, and the duration of going on sick leave before they actually go and get some sort of help that will make a difference. This finds also that high baseline somatization, so that's physical health disorders as a result of psychological symptoms and anxiety, and high depression. So there's just a few pointers there, and I will sum up this in a bit. This is another study that found that actually people who reported stress or burnout were more likely to return to work than people who actually had a clinical depression. And also another thing that was helpful is someone who actually had an expectancy of wanting to return to work. So actually they didn't want to stay away, they actually wanted to go back. And if you hadn't had prior mental health problems that had been associated with sickness absence, that was obviously a good thing as well. And the last one I want to put up of these three is this is looking here, again, found that depression predicted a longer time to return to work. These are hazard ratios. So depression again comes out here, and people as a negative predictor of return to work, and that better self-rated health, so doing better, having less severe problems, stress and burnout rather than clinical depression, was also useful. So the summary, I think, of those three papers, and there are a few others, is that the severity of the problem, particularly depression, seemed to have a worse outcome. The longer it goes on for without treatment, the worse the outcome. and the employee's view about return to work is also an important factor. If they don't want to go back to work, it's going to be really hard to get them back to work. What sort of treatment matters? There's obviously the mental health treatment. There's a lot of different treatments out there. I'm not going to go through them all, but I think the two papers here I want to draw out is a really important point here, which is that return to work is much more likely when you have an occupationally focused treatment. And so I'll just try and move my thing here. So if you can see here, which I put here, is that this looked at normal cognitive behavioral therapy and work-focused cognitive behavioral therapy. And they found that the people who had work-focused cognitive behavioral therapy tended to return to work on an average 65 days earlier. And this led to, in the States, a definite financial advantage in people who had work-focused treatment. This is another one looking at the same sort of thing. And this found that actually, if you had a brief CBT with both intervention, but with workplace intervention, so again, focused on getting people back to work, was superior to standard CBT. And this led to a little bit earlier partial return to work, but a much earlier full return to work. So what this tells you is actually having treatment which is focused on return to work, not just on getting people better, is really useful in terms of getting people back to the workplace. So what outcome can you expect? What proportion of people might you actually get back into work? So this is a study we did a few years ago now on British military, and we found that after treatment in a military department of mental health, so these are people most commonly with common mental health problems rather than serious mental health problems, we found that 68% were in back to full work after 6 months. So obviously this is the military. The military requirements are pretty exacting in terms of what they need. So I think this is showing that if you do get occupationally focused treatments, if you hopefully nip things in the bud and you hopefully get them early, it should make a positive difference. So what might help with return to work problems? So we know that probably one of the most important thing about being at work and also returning to work is about social support. And social support works in kind of two ways. One is by what's called stress buffering, which is this idea that the people around you can share your difficulties with and they support you. But it's also about being part of the right organization, feeling that you're part of a team, feeling that you have some sort of sense of belonging. I'm in this group, I'm in this team, I'm in this company. So there's something about having that right culture, which can almost back people back to work. This is a study we did on military peacekeepers who come back from the former Yugoslavia. And we asked them who they spoke to about their difficult experiences. And 97% said they spoke to people who were just like them, who had the same experience. Only 8% went to see medical welfare staff. So I think what this tells us, quite importantly for return to work, is actually the people who are at work are an immensely useful source of social support, and that social support is likely to be helpful. One of the more important things, though, than just what your colleagues think of you is also what your supervisors think of you. And this is data from Afghanistan in 2010, and this looks at people who are your immediate line manager. You can see here what we used to classify people as being good leaders. So it wasn't about being effective at doing their job. It was about supporting troops and not taking on extra duties to make themselves look good and being a decent welfare-focused leader. Overall, in this study, about 3%, just less than 3% have PTSD. But you can see here there's a 10-fold difference in the rate of probable PTSD between having what you thought was a good immediate supervisor and having a poor immediate supervisor. So that's a really big impact. Great study done in Australia with firefighters managers. They train the managers in some of the fire stations to be able to speak to their staff about mental health problems on a short training course. They did a randomized controlled trial, published it in the Lancet Psychiatry, and what they found is that for every £1 spent on that training, they saved £10 in sickness absence over the following 6 months. And the most important thing was that the supervisors felt confident to discuss mental health. We've done similar sort of thing to this with the NHS over the last 6 months. We developed an intervention called REACT, which is a short training course. It stands for Recognise, Engage, Actively Listen, Check Risk, and Talk About a Specific Plan. It's an active listening skills package. We delivered it to a whole host of NHS supervisors, but we did a small pilot where we measured before they did the course, and then 1 month after they'd done the course. So before they did the course, over half of the managers who did it felt that they were underconfident in supporting their colleagues. 1 month later, having done the course, over nearly 85% felt confident. So that's a big shift in people's confidence in speaking about mental health, which that previous study shows should make a really positive difference in supporting staff. Things you should consider when people are going back to work. I think the HSE management standards are a good place to start. There are lots of different pieces here that I won't go through in detail because of time, but all these stressors are likely to have an impact on people, not just in keeping them fit and healthy in the first place, but on their ability to go back to work as well. So I think it's definitely worth thinking about those in a return to work plan. Practical considerations, I think, are when do you restart work? So if you've got someone and they started treatment and they're going on, when do you get them back to work? And I'm sure Reema will speak about this and Chris much better than I will, but basically you want to get them back to work, in some shape or form as early as you can, but you need to liaise with their therapist to make sure that you're not going to cause them to have further difficulties. Flexibility, how can you alter their time? How can you alter their role? If it's a trauma exposed role and they're being treated for trauma, probably not best they're exposed to trauma whilst they're getting back to good health. Supervisor and colleague support is really important. One of the challenges for you though is what can the supervisors and colleagues know? What can you tell them about the person's mental health? Because of course confidentiality needs to be respected. Obviously in a good team, hopefully something that there's enough trust that you can talk about it, but that's something that I think psychiatrists and occupational health professionals need to know, because I think it is helpful for people to know something about the individual's mental health. Obviously, occupational health is really important in having oversight, particularly in the more complicated cases, plus or minus an occupational psychiatry opinion, if there's actually a mental health problem that is complex. Got to think about risk management, back to those safety critical roles that I mentioned. If you're in a safety critical role, really important you don't give people too much responsibility too early, because if they end up making mistakes, that's not just bad for the outcome of their job, but it's also bad for their own self-esteem. And then you've got to think about persistent work stressors. Was it something at work like relationships with colleagues that led them to go off work in the first place? Because if you don't address that, then you're not going to be able to get them back to work successfully. And then don't forget other life stressors, what's going on at home, children, sickness in the family, financial difficulties, because that will also have an impact, even if you consider that it's not actually your responsibility. So in summary, workplace stress and frank mental health problems are on the increase. It seems it's good news for people in occupational psychiatry. They can lead to a loss of employment and productivity, and this is especially important in safety critical roles. What the evidence seems to show is that longer, more severe illness leads to worse outcomes, and that you really want to make sure that you don't just get people to get treatment. You need work-focused treatment, because having work as a treatment outcome is really important. Adjustments, reasonable ones, of course, can make a big difference in safe and social support. Really encourage you to actively manage risks, and that sometimes means some sharing of information with important others in the team so they can monitor. And I think you can expect a good return to work outcome if it's handled properly, and particularly if the employee is motivated to return, which hopefully will be helped by them having a good place of work to go back to. So that's me. I'll happily take any questions.
Thank you very much, Neil. That was really interesting. We've had one question. Oh, we've got another one now. From Shera. Will the REACT programme be available outside of the NHS?
So it is. So I have a conflict of interest. My company, March on Stress, provides REACT training, so you could definitely contact us and we'll be delighted to sell it to you and to deliver it. But what I will say, rather than trying to sell REACT per se, is I think what you should be looking at is for all your supervisors is to make sure that they have enough skills or confidence or experience to feel that they can have a conversation about mental health with their staff. So once you start those conversations about mental health, actually loads of positive things flow out of that. There may be workplace adjustments that you can easily do that will reduce someone's stress immensely. There may be risks associated with someone's jobs that you were never aware of because you hadn't really talked about it. And so, yes, REACT is available. You can buy that from us. But I think whatever you decide to do, I think putting in place some simple strategies to help managers feel confident to speak about mental health is really important. And one thing that you might want to look at, which is cost you absolutely nothing, is on the Public Health England website, they have a package called psychological first aid. Now, it's more than active listening, but that psychological first aid package has been well used. We don't yet have evidence that makes a huge difference, but I'm very, very confident it's not harmful and it doesn't cost you anything, and it might be a place to start as well.
Thank you. I've got another question here from Julie Lawrence. It's disappeared, but from memory, it was, what's the difference between the training you just talked about and mental health first aid?
Okay, so mental health first aid is a 2-day course, and or at least the main course is, and I'm not a mental health first aider, but I know a bit about it. It's about learning about different sorts of mental health difficulties, and then giving you a sort of technique to allow you to engage with people who might have difficulties. I think the key thing about that is over 2 days it can give you quite a lot of information. What the React course is, an hour and a half, and it's specifically focused not on giving you lots of information about what mental health is, although it mentions it a bit. It's about giving you that confidence to start what I call a psychologically savvy conversation, and then to come up with a plan about how to make things better. So React is very much more of a bite-sized active listening skills package aiming to improve confidence.
The other comment I would make is that the downside of mental health first aid training is it's very reactive rather than proactive, thinking what managers can do to make their workplace much more mental health friendly. And I really like the way you talked about the HSC standards, thinking about demands and control and so on. I've got another question here. Oh, Louise is saying mental health first aid can be delivered in 1 day. I've trained as a mental health first aid trainer, and the course I did, it was a 2-day course, I'm sure, but it was quite a while ago. So I did
the course in 1 day.
Oh, okay.
It was good. I did it. It was actually commissioned by the Royal College of Veterinary Surgeons as part of their Mind Matters initiative.
All right.
So I'm sure you guys will all know much more than I do about the fact that vets as a profession have a terribly high rate of suicide.
And they've also got access to the means to end their life by suicide. Thank you for that. I've got another question. Good, Neil.
John's got his hand up as well, I can see. And he's
John, over to you then. Can you ask a question?
Okay. Hi there, everyone. Neil, hello. Really good to see a paper on your presentation that has my name on it too. So I just thought I'd ask a question, sort of a general thing, mindful of your presence on Radio 4 earlier this week about healthcare professionals. And I'm also mindful of an assessment I did very recently of a doctor, where I was having a bit of a sort of ho-hum whether he could go back to work clinically. And it kind of centered around, one of those things where you got a bad feeling when you were doing the assessment about whether they were being honest with you, et cetera, et cetera. So it made my sort of risk assessment kind of colored in that way. But I just thought I'd say, have you got anything to offer which is specific to the kind of decision to let healthcare professionals back into, I say let them back in, to encourage them back into their workplace, but mindful of the risk of the safety critical issue?
It's a really good point. It's something actually that you probably heard of the practitioner health program that Claire Gerardo started off and runs, so which particularly looks at doctors and dentists. So I think having spoken to Claire and having looked at this in a lot, I think the key thing here is about the safety management plan. So I think if you have someone who is risky and you're thinking, well, I do want to let them back because that's really important for their self-esteem, and also we need the staff back at work, I think the thing is about what's the plan. And so if that person says, yes, they're happy to let their supervisor or a trusted other or someone else know that there's a bit of risk there and to keep an eye on them, that's much more confidence building than someone who says, I don't want anyone to know, but I'll be okay, doc, do let me go back. So I think it's about putting in place the proper mitigations, and then obviously, reviewing it in whatever you think is clinically appropriate. But I would be wary of just letting someone go back, on their own terms with no one else knowing, because I think that there's a potential for some real disaster to go on there.
No, I agree.
I'm going to have to.
Sorry,
I'm going
just
to have to
I'm going to slip
wind
off
the
at
questions
3
up in
o'clock.
a second. Yeah. I'm going to wind up the questions in a second. Otherwise, we'll run out of time for our other speakers. But if you'd like, those people who've got their hands up or want to ask a question of Neil, write your question down. We can have some time at the end to come back to it. But I do note that you were saying that you've got to slip off in a second. Could you do your final sort of 30-second comment that you wanted to get in? John?
That's you, John.
Oh yeah, I was just trying to unmute. No, sorry, I wasn't going to make a final comment. I just wanted to say I didn't want it to look rude. I got another Skype meeting at 1500, so I'll leave at that point. Thanks.
That's fine. Thank you, John. There will be a recording available for the elements that you will not have caught up with. But thank you for telling us that. Okay, well, thank you, Neil. That was really interesting, and be prepared for a few questions at the end, because we've got about 5 to possibly 10 minutes for that. So now I'd like to pass on to our second speaker, Dr. Reema Kibreab. She is an expert in vocational rehabilitation, and I'll leave you to just introduce yourself a little bit more, because that seems a very scant identification of what your skills are, and to then do your presentation, which is going to be on individual placement and support. Thank you. Over to you.
Thank you. Thank you. So a bit about my background, just to clarify, I'm not a doctor. I work as an employment advisor. I've been in the role for 2 years. I'm based in the early intervention service in Hammersmith and Fulham, and I work for Richmond Fellowship, which is a mental health charity. My colleague Chris Browne will be joining me for the presentation. Are you okay to share the slides on your end, Chris, still?
I'm okay to do it. So I just need to know that everybody else can see it, really. So
I think if you share the screen.
Just share the screen now. Let me do that.
So are you starting it off, Chris?
I will be. I've got the slides on my side.
Brilliant.
So let me just share my screen.
By the way, while you're doing that, I can see we've got 110 participants, which is absolutely fantastic, and from a range of professions. And it's really interesting that Louise is a vet. So it's not just people looking after humans, it's people looking after animals.
I'm a doctor, I'm not a vet.
Oh, are you? I'm so sorry. I thought you said you were...
No, it's just that we're doing a doctor support network as an anti-stigma campaign with the Royal College of Veterinary Surgeons.
I understand. Thank you.
Sorry.
Okay, that's all right. Thank you, Chris.
Is everybody able to see the screen here?
Yeah.
We are, okay. So hello and welcome everybody. This is the IPS presentation on individual placement and support, in particular returning to work after a mental health crisis. My name is Chris Browne. I'm Service Manager for Richmond Fellowship at the Hammersmith and Fulham Employment and Wellbeing Service. And my colleague...
Hi, I'm Reema. Yeah, as I said, I'm employment advisor. I work alongside Chris in the Hammersmith and Fulham Employment Service.
Okay, and Reema works in the early intervention service.
Yeah.
So we're just going to tell you a bit about Richmond Fellowship to begin with. So Richmond Fellowship, for those who may not know, is a charity that has been going for something like 60 years. I think that celebrated a couple of years ago. And the main provisions that are available are employment services, community-based support, crisis services, supported housing, residential care homes, and social enterprises. And Reema's going to say a bit about the mission of the organisation.
Yeah, so our mission at Richmond Fellowship is to make recovery a reality for all. Our vision is to help create a society that values everyone with mental health problems. And our values are enabling, inclusion, respect, and hope.
So the Hammersmith and Fulham Employment Services has 7 employment advisors, and they're embedded in 3 NHS multidisciplinary teams. In the IAP service, in primary care, we have 2 full-time employment advisors. In vocational recovery services treatment and recovery team based at the Claybrooke Centre, just on the Charing Cross Hospital site in Hammersmith, we have 3 full-time employment advisors and 1 part-time employment advisor. And today we have Reema with us, who is the 1 employment advisor who is based in the early intervention service. So all of our employment advisors, they all operate under the individual and placement support model. And Reema's going to say a bit about the IPS history.
Yeah, so IPS originated in the USA during the 1980s. It was pioneered at Dartmouth Psychiatric Research Centre and then went on to be piloted in the UK in 1998. IPS is also known as evidence-based supported employment, and in a nutshell, it basically addresses the problem that the majority of mental health service users do not receive support with finding paid work.
So the individual placement and support model has 8 key principles, the first of which is zero exclusion policy. So there we cannot object to anybody coming to our caseload based on their mental health presentation, whatever their diagnosis is. The employment service has to be integrated within a mental health team. And another tenet of the IPS is that we have a rapid job search. So we heighten the expectation, we don't lower the expectation. If somebody has a mental health difficulty, we say we're going to help you to search for a job quickly. And we search for competitive employment based on the client's preferences, and we'll engage with employers based on those clients' preferences. IPS is time unlimited support. So as long as the person on caseload requires employment support, then our employment advisors will help them. And also, which is very important, we offer benefits information, because that can be a high point of anxiety for somebody with mental health difficulties if they're on benefits, and the slight trepidation about losing those benefits and going into employment might cross their mind. So Reema's going to talk a bit about the IPS fidelity scale.
Yeah, so in short, the IPS fidelity scale basically measures the quality of an IPS service that's being delivered. So there are 3 sections to the scale, one of which is staffing. So we've just picked out some highlights. So the number on caseload of an employment advisor is really important. An employment advisor should only have 20 or less cases on their caseload. And the reasoning behind that is so that they can provide their clients with, focused and dedicated support. Vocational generalists is another word for basically an employment advisor. So it basically reflects the different phases of employment support and just captures an employment advisor's role. And I will go into a bit more detail about that in my case study.
Okay, so Reema will talk a bit more about that shortly. And so there are 3 sections, as Reema mentioned, which is the staffing, as you've just seen. There's organisation, and then there's also services, which we'll come to in a moment. So the 3 highlighted elements we're going to show you here is around the integration with the community mental health team. So that's working with the different NHS clinicians, occupational therapists, and also local authority, whichever organisation they're working for, all together in a multidisciplinary team, social workers, community psychiatric nurses, psychiatrists, such as many people on this call, and psychologists. And if anybody that one of those clinicians has their care coordinating for, they can say, oh, this person's mentioned that they have an employment aspiration, and can one of your team support that person to find employment? Also, the frequency of contact with the multidisciplinary team, obviously through meetings and case conferencing, and different ways that we work in assertive outreach in the community, working together with people on caseload. So those are some of the important parts that employment service should be in a mental health team, to get that support from other experienced clinicians in areas that we don't have experience in. Also, the collaboration, as I've mentioned, in regards to benefits, that all employment specialists, especially now at Hammersmith and Fulham, we have a good rapport and partnership with the Job Centre Plus and the DWP, who send us lots of information around employment fairs, and if anybody body on caseload has questions or queries around their benefits, our employment advisors have a direct link to disability employment advisors and job coaches within a Job Centre Plus. And Reema's going to say a bit about services.
Yeah, so time unlimited follow-along support is one I picked out. Chris touched on that in the 8 key principles. So it's basically the idea that vocational support doesn't end if the client doesn't want it to when they start in the role. So you can kind of provide support to them whilst they're adjusting and checking in with them and just being on hand if they need any support or advice. So that support is still open to them once they're employed.
Thank you. And also we've highlighted the disclosure. So working with somebody around when they may or may not want to talk to their employer about their mental health difficulty. So all employment advisors will support people when they're finding a job, and this may come up as an issue that the person may be comfortable. Sometimes people aren't comfortable because they feel they won't be get discriminated against by an employer. So we'll talk with them and support them and tell them about things like the Equality Act 2010, how it can't be discriminated against their disability or if they have a mental health difficulty. And it is a protected characteristic, but at the same time, let them know it's their decision. We'll weigh up the pros and cons with them, and however they feel about it, we'll support them through that process and talk to them about possibly the best times when to tell the employer, how to say it, you know, not necessarily just to blurt it out as you walk in the door and, you know, present yourself sort of very anxiety laden. So we'll work around that, but definitely telling the person that it's their decision and we'll stand by them, whichever decision that they care to make. So in terms of the IPS model, it's an evidence-based practice. There have been clinical trials. As we mentioned before, it originated in the United States, so they're ahead of where we are with it in the United Kingdom. And they've done clinical trials there, they've done clinical trials here also in the United Kingdom. And it's been proven against other vocational service models that an individual to place somebody in employment and to support them whilst they're in employment is much more effective than just finding them a job and leaving them to do what they do. And also the other side to the evidence base is around the client management systems that we use in IAPTUS, in the primary care, IAPTUS client management system and the RIO client management system in secondary care to hold information such as case notes and appointment diaries, and also other elements of work such as the IPS pathway, which will then capture the whole journey that the person has when they come into an employment caseload and right the way through. So Reema's going to tell you a bit about her case study directly related to somebody who's helped back into work.
Yeah, thank you, Chris. Yeah, so I'll be going into details about a client who returned to work after experiencing an episode of psychosis. But firstly, I just wanted to outline the different phases of employment support that captures a vocational generalist / employment advisor's role. So there's the intake stage, the engagement stage, there's assessment, job placement, job coaching, and follow along support as well. Okay, so Roger, which isn't the client's real name, is a 29-year-old male that was referred to the early intervention service after experiencing an episode of psychosis. So upon Roger's referral to EIS, he spoke of his keenness to get back to work because he felt that it would help provide him with more structure and purpose in his life. So 2 months later, Roger was ready to start searching for work and a vocational referral was made. And just to give this some context, this was during COVID-19. So at the point of his vocational referral, Roger had been out of work for 10 months and had stopped due to problems with his mental health and alcohol and drug use. So Roger told me that he was struggling with feelings of isolation and had lost the social element of being at work. So I completed an initial assessment with Roger to discuss his vocational goals. We completed detailed CV and covering letter work and started the job search process within the first few sessions of vocational support. So Roger had a background in fitness, but gyms were closed due to the lockdown. So we were expanding our job search to retail positions. So Roger found that he wasn't hearing back from a lot of employers and felt quite disheartened by this and was questioning the lack of responses. So obviously I emphasised the difficulty of the time to be looking for work, where there were obviously reduced vacancies, most likely more competition for roles as well, and really encouraged Roger to persevere with his efforts. And he did remain determined with his job search, expressing to his doctor that the routine of a job would help him with his mood, provide him with something to concentrate on, and also be a worthy distraction. He thought he would find this quite beneficial. So as gyms began hiring again, Roger began to receive interview invitations, and we conducted interview preparation. He did attend an interview for a part-time fitness trainer role and was successful in securing the position. He did want to look for a second part-time role alongside this. We had sessions in the lead up to his role and also once he was employed. So Roger informed me that he was settling in well, he liked the team he was working with and was also getting involved in some social activities with his colleagues as well. So as Roger was looking for that second part-time role, he continued to submit regular job applications and attend interviews, and he quite enjoyed that process. You know, he reported to be doing well. He was feeling really positive about the invitations he was receiving for interviews, and he said that they were also keeping him really busy and focused. So Roger was successful in securing another position, which was a part-time fitness supervisor role. He settled into the role comfortably, describing it as quite relaxed, and he worked in this role alongside the first job he had secured. So in terms of his current situation, Roger continues to be employed as a part-time fitness supervisor. He left the first role he'd secured due to the distance of the workplace from his home, so we are continuing to look for additional fitness roles currently. I think with Roger, like, it's good to point out, he was very autonomous during sort of vocational support. He kind of, you know, was comfortable making applications independently and hasn't required a lot of input in his regarding his current employment. But obviously the support for each client that's required, it can vary. So you can have clients who need a lot more support around job applications or kind of confidence building or motivation and things like that. So that can obviously vary from client to client. Thank you.
Thank you, Reema. So also, as Reema's just highlighted the case of where it's worked well getting somebody back into work, there's also the topical issue of the pandemic. So at this time we had to adjust our services and many services went to telephone calls. There is also the option for calls like this virtually with Zoom and Microsoft Teams, but there's also some privacy issues around that. So it's sometimes more safe to do on telephone. It also the pandemic affected our referrals just in one of our teams, namely the vocational recovery service. The referrals seemed to dip, but in early intervention service and IAPT, we did have still remain a peak in referrals and a more consistent level. And advertised jobs, whilst they did decrease, we did successfully secure job roles for clients, as Reema has highlighted in her case study. So we've also included here some further reading for people who may not be that familiar with IPS. So the first two named organisations named that are in the UK, which are Centre for Mental Health and IPS Grow. So the Centre for Mental Health have a long-standing history of working with IPS in the UK. There's some research evidence there, some links, and also IPS Grow are one of the main services that are commissioned to work with IPS employment teams. And we've also included the IPS Works, which is where IPS itself originated in the United States. So there's some information people can pick up on there. And finally, that is our contact details for myself and Reema. And if we can answer any questions at this moment or in the future, or if we not too sure, we can always signpost you to the appropriate person. So Reema, is there anything else we've missed out you'd like to add?
No, I think you've summed it up perfectly. Thank you for listening.
Okay, thank you everybody for having us, and if there's any questions, we'll be happy to try and answer them.
That's lovely. Thank you so much for your presentation. I'm mindful that certainly Patricia had a question for Neil. If you could just put that in the chat box, we'll pick that up at the end, but we'll go to any questions about this presentation that Reema has just undertaken. Any questions there? If you could raise your hands or put things in the chat box. Actually, raising your hands might be better. Any questions for either Chris or Reema? Okay, I'll move on then. So if anything comes to mind during the next presentation, save them up and we can deal with them in that final section at the end. Excuse me. So we're now going on to our third presentation, which is going to be given by Dr. Roxane Gervais. Roxane is an occupational psychologist. She's done an awful lot of work with us at SOM and was integral to leading the team that developed the SOM Return to Work toolkit. That toolkit is available on the SOM website, and I'd strongly recommend you accessing it. As I say, there's no charge, and it's been accredited by the Royal College of Psychiatrists, and I think also the CIPD, but I don't have it in front of me just to confirm it. So Roxane, if you could unmute yourself, share your screen, and over to you. And for the audience, keep thinking about your questions and either raise your hand when we come to the section where you can ask questions, or put them into the chat box. Thank you. Roxane.
Thanks a lot, Anne. Thank you for that introduction and for reminding me to unmute myself, because I always forget. I'm wondering, why can't anyone hear me? So if I can now share my screen. Hold on. There we go. Can everyone see that? Lovely. Okay, as Anne was saying, my name is Roxane Gervais, and I'll be presenting today on the SOM's Return to Work toolkit, which, as Anne has said, is on the Society of Occupational Medicine's website. I'm sure Nick, if he's on, will pop the link in for you so you can know exactly where you can find it. A little bit about me, lots of words there. It just means that I keep busy a lot. So I'm a chartered psychologist, chartered scientist, registered occupational psychologist, also an associate fellow of the BPS. I'm an independent researcher, practitioner, and consultant, which basically means I work for myself. My expertise is in occupational safety and health, which allows me to support organizations in managing the work-related stress and other work-relevant mental health issues that arise around the employees and within the organization itself. And because I'm an occupational psychologist, I also do all those lovely things that we tend to do in terms of research, surveys, assessment, psychometrics, development, looking at organizational change, and developing individuals within the organization. So why do we need a toolkit? That's a very good question, because when we developed this, I think it was around May last, was it? When did we finalize it? Somewhere in the middle of last year. And at that time, we thought at some point in time, we would actually get back into the workplace. Yes, we were a bit optimistic about that happening. But at some point in time, those who have not continued to work and those who are working more within the service industry might get back into the workplace. So we needed to add a resource that can actually help organizations and individuals in understanding what they needed to do to get back and be more effective within their workplace. It provides information and guidance, and also offers focused and practical solution. So why do we need to continue to focus on making sure individuals are healthy when within the work environment? Neil provided quite a lot of context around the increases in work-related stress. And interestingly, this year, last year, at the end of last year, when the Health and Safety Executive released their work-related stress, anxiety, and depression statistics, there was a huge spike. I think that's been the highest spike in about the last 10 years or so. And these results were also not linked to COVID-19. They were naturally occurring on their own. So we know that work-related stress, anxiety, and depression continue to be issues that organizations are struggling with because workers are not remaining as healthy as they should be staying within the work environment. And this is a figure from, could everyone mute their mics, please? Thank you. And this figure is from the Council for Work and Health, which I think shows that we want to prevent harm, which means that people are healthy, they're well, they stay productive, they perform at the optimum. And that actually is the cheaper option, as Neil showed, for every return you invest in keeping people healthy, it means you have a large return on the investment. But if you go to just managing the effect where they cannot function as much as they should, as much as they could do, then you've got all the expense of rehabilitating them, diagnosing, trying to figure out what's wrong, providing the resources to make sure that they can then get back to health and retain their health over the long term. Because it's very expensive to actually replace any worker within the workplace. It can cost for anywhere from 25, 30, 40, 50,000 pounds to actually replace someone who has left the workplace because of work-related ill health, especially with work-related mental ill health. So it's a lot more cost-effective to keep people healthy than actually making them ill so that they have to leave the work environment. Okay, well, that was lovely to hear. So how should we prepare to return to work? And again, when we think of return to work, we tend not to think that a lot of people continue to work, doctors, and everyone thinks, well, it's the healthcare. But there are a lot of industries where people have actually remained working, not only the supermarkets, there are lots of people who still, even though they're not in one of the service industries, are still being made to go into the work environment because your employers are saying, you have to come in. We've got the place COVID safe, but we still want to see. So there's this aspect of visibility still being, that is still occurring over a lot of the industries within the UK, regardless of what is happening with respect to lockdown and the pandemic. So when we're saying return to work, we're talking about those industries that have not been having their staff working remotely. And also some of those industries where they can think about, okay, what else could we be doing when all the staff get back fully into the workplace? So there are also some industries where some of the staff are working, some staff has still been furloughed, and some staff have been let go, and some staff are working from home. So you've got all these different permutations of what is happening within the work environment at the present time. But at some point in time, I can't say when that will occur, we will get back to the old normal in terms of the majority of people will be going back into a physical work environment. And I know a lot of employers are saying that they would have a sort of hybrid approach and there might be a lot more employees working from home. But a lot of employees might not want to be working from home full time. And also, I'm a bit cynical in that I think once we get back to what was some sort of normality pre-2020 at the end of 2019, a lot of organizations again go back to the visibility aspect of seeing people to think that they're working effectively. Some organizations might decide to, have employees within the workplace 2-3 days, or some might have them back 5 days a week or 7 days a week. But it's never going to be what we have now. And I think I'm cynical enough to say that what we have now is not going to be normal moving forward. Because again, we've got this aspect of trust within organizations where you have to see someone to be comfortable that they're doing what you think you want them to do or what they think they should be doing. So Now, the return to work process should always be done across 3 levels. It has to occur, firstly, the primary level at the organization level. Then we have to look at the group and team approach, which is the secondary level, the second element at which we should be looking. And then only then should we be focusing at the individual level. Because once we start at the organization level, everything should be in place. But we should not really need to focus on making sure that things fit for the individual, because if you're trying to focus on fixing the individual, rather than making sure that things are working as effectively as they could, then again, the cost goes up, it becomes more problematic, and things do not go as smoothly as they should. Now, I like this image as well, that I tend to use quite a bit, and it shows how we should be managing stress. And this doesn't only work for stress. I know it says stress because that's how it was designed. It also works for anxiety, depression, and also fatigue as well, which is more the work-relevant mental health conditions. Again, you have to start at the base. Now, we tend to use a triangle because it shows that the largest investment should go at the primary level, the largest part of the triangle. That is when we're trying to prevent ill health from occurring within the organization. That's the preventative stage. So you have to make the changes that are pertinent to making sure it covers 100% of the organization. So that everyone, we're making sure that everyone is being assessed as it should be assessed. And then we move up to the secondary level, which is a bit more defined again. Now, in terms of even managing stress, we tend to look at resilience, building individuals' ability to cope. But we also have to look at how can we, in addition to building resilience, how can we make sure that they have the information they need, they have the resources they need, the teams are working effectively, line managers are functioning as they should be in supporting the employees. And when those things are functioning effectively, then we go to the tertiary level, the individual level, which is reactive, because at that point in time, the individual is probably on long-term sick, short-term sick, and might be struggling to come back into the workplace. If they're not on sick leave, they're probably engaging in presenteeism, which means that they're basically not fit enough to work, as Neil has mentioned in his talk, but they're still reporting to work. So even though they're visible, they're not productive, they're not performing as well as they should, and they're not contributing as well as they could to the organization. I'm just looking at my time here. I think I'm fine. So if we then take the 3-step approach and apply it to the return to work process, again, we have to start at the organizational level. And the same way in terms of thinking about keeping people safe, healthy, effective, we have to look at job design. When you're trying to get someone back into the workplace, and especially after post-COVID-19, post-lockdown, post the pandemic. Now we know that jobs have changed since we've been in lockdown. We might have had role creep where people have been asked to do different things because, someone might be around, people might not be as effective as they could be. So we've had role creep, we've had role sharing. So jobs probably would have changed a bit. And the organization needs to think, okay, well, are these jobs the same as they were before COVID-19? What has changed? And also what needs to change? The organization might think, well, we should be doing things differently. So before they get people back into the workplace, what should the jobs look like and what should be happening? What are the stresses that people are going to come back into the workplace to meet? The stresses, unfortunately, are not going to go because the change is constant. The change is constant, it keeps happening. We know this is happening. Again, leadership is a leadership fit for purpose. And I know there's been a lot of talk about, especially with COVID-19, which leaders have worked effectively, which has not. And the same thing, and that is at the country level and also at the organizational level. What sort of leadership do you want? What are the risks you need to be looking at? Are you providing the relevant training? What is the training that you provide? Is it useful, or is it just because it's a tick box? You say, well, you've given them training. Is it actually going to add value to the employee, to the workplace? Are you involving the workers? Are you communicating with them? Are you allowing them to communicate with you? And two of the least expensive interventions you can have within any organization is to involve the workforce and to communicate with them. It's cheap as chips, and it's very, very effective. It doesn't cost anything, and it actually keeps people committed to the work environment because they know what's going on, they can contribute to it, and it helps them feel involved, it helps them feel supported. And then we go up to the secondary level, which is the detecting what's going on in the work environment. So again, you have to assess the work stresses. And again, we're going to keep on talking about assessing work stresses. And Neil kindly highlighted the HSE's management standards, you know, demands, resources, change, relationships, which is a good starting point. Again, it's free, so you can use it to assess what's going on in the organization. Again, we have to train individuals, and we have to adopt a nip it in the bud approach. Make sure that we pick up on all these minor issues that could lead to major issues, so that we say, okay, what's going on here, especially within the team roles, you know, what is happening? What can we do to smooth this over, make sure things are working effectively? And then when we focus on making sure that the group or team level is effective within the organizational approach, we can then move up to the tertiary level at the individual stage. Again, we looked at the individual then and say, okay, what are the work stresses? Are we giving them the training? Do they have access to occupational health services? Do they have access to employee assistance programs? So if an organization can't afford these issues, can you have some sort of system where you can, again, any sort of peer support system would be valuable here. It doesn't have to be anything that's concrete, but it cannot be the only intervention or resources in the organization. So like Neil mentioned, you've got the REACT approach, you've got mental health first aiders, but they can't be the only situation at the tertiary level, because it's not going to solve the issues if the stresses are still there, if the jobs aren't designed properly, if the leadership is not functioning as it should, if the risk hasn't been assessed. Just focusing on, you know, a peer support system is helpful, but it's not the answer to making sure things are working as effectively as they could. And then when you get to the team level, you can start at the tech level. What is going on? Have you trained your supervisors and line managers? And we know a lot of the research shows that line managers can be a major stressor to a lot of employees. That's where, and people tend to leave, as you know, there's this saying that people tend to leave their leader or their supervisor rather than a job, because then you have the friction, you don't have the support. It becomes more problematic, and the supervisor or line manager is then an actual stressor to you rather than a support system. We need to enhance the support between team members, and we, you know, get looking after each other, and that all of that has to happen at the organizational level, even though it's focused at the secondary level, if that makes sense. That's what I'm saying. You know, at every level, you have to take a three-tier approach. And again, at the team level, if you're looking to detect what's going wrong, is there the appropriate training in place? Have you assessed psychological safety? You know, and psychological safety is more a concept of, do you feel comfortable? Can you ask a question? You know, are you feeling safe? Is it a non-threatening environment where if you speak up, you'll not be shut down? You'll say, oh yeah, that's interesting. Let's talk some more about that. What are the support systems in place? Can you assess workability of employees, especially those who may be more vulnerable? And there's a workability index that's free to use, available to use. It's fairly simple. I don't want to say it's easily. It's fairly simple, and it allows the individual to say, and also it can work for the individual and the teams. What's working for me? How can I improve it? What else do I need to be doing? Again, is this a peer support in place? Can you empower supervisors? And not empower them to harm their supervisees, but actually make sure that they stay healthy and safe and continue to contribute. And then at the individual level, where you can treat the illness to make people get back into the workplace, are you remaining in contact with people who may be on long-term sick? And it doesn't have to be a sort of abrasive or continuous. Make sure that they know that you're there for them. If they want to speak with you, they can speak with you, they can get in touch. But again, remember that if someone is a year or to 18 months out of the workplace, it's highly likely that they will never return to the workplace. And you've got that cost of trying to replace the person, which can cost 25, 30 pounds. And then you have the 2 to 3 years of actually then training the individual who's coming in to replace the person who left because they did not want to return to work. Are you providing the required workplace adjustments, which is a legal requirement? And are you allowing the person to get back into the workplace by a subtle, calm return to work? Now, this can be a form of presenteeism, but it's a managed form of presenteeism in that the person is not at 100% effectiveness, but you're getting them gradually back into what they will be doing and being able to function within the climate that they're coming back into. So in terms of managing the presenteeism where they're not fully fit, but they're being encouraged to come and do what they can, that means that they will return. What's that? Okay. Moving right on. Sorry about that. And then if we go to the individual level, again, if you look at the large base, you know, are the individuals informed? Have you prepared them? Can they ask questions? Can they involve the family? And again, you have to have an organizational culture that encourages these things. At the group or team level, individuals encouraged to seek help, engage with support systems. Can they actually cope? Are you giving them the freedom to be able to cope as they can? And then at the individual tertiary level, what are the support systems that are in place for these individuals? What training is being given to them? Can they assess their workability? Are there, you know, some form of employee assistance program, whether it's a formal setup or a more informal setup? Is there counseling available? Can they make sure that when they get to their general practitioner that they can actually, you know, highlight what the issues are, what support they need, whether they've got a footnote, and when can they return? Are they supported in the return process? Now, as Reema and Chris was saying, you always have the individual differences. This is when we need to really think about the individuals and getting them back into the workplace. You do have those high risk groups, and while you have to think initially at the organizational level, when it comes down to you still have to focus on the individual at some point in time, because there would always be people who would not fit within the major organizational change, but these are very few. And these are people who would fall into one of these conditions. They've got a pre-existing condition, they're vulnerable. And again, within the COVID-19 context, they may have been shielding, they may have been acting as carers. You also have those persons with increased disability, increased vulnerability. They've got a disability, they're fearing discrimination, as Reema and Chris says. They've got a long-term mental ill health issue. And of course, you always have to be aware that under the 2010 Equality Act, they have to be treated as fairly as possible. So, and we also have to remember at the individual level, because we also have to look out for our own health, mental health, well-being, and under the Health and Safety to Work Act as well, organizations have a duty of care to make sure that they ensure that they do not bring harm to individuals and the workforce. But the workforce also has a duty of care as well to themselves, to make sure that they're able to look after themselves. They question things, they request the training, and they focus also on keeping themselves healthy. And you also have to invest in self-care. Are you getting enough sleep? You know, sleep, especially quality sleep. You can sleep for 10, 12 hours, but is it quality sleep? So you might get the quantity of sleep, but is it restorative? You know, are you in that deep sleep where your brain starts to click and, you know, make sure that it's actually repairing itself and repairing the body? Are we keeping physically active? Are we eating healthily? Are we relaxing? Are we not ruminating? Because if you're ruminating, thinking about something that happened, thinking about the stress that's making you ill, then that begins to affect everything. You know, physical activity might stop. You might start to, you know, drink a lot more, eat a lot more unhealthily. You might not be sleeping as well. So you need to relax. We also need to socialize. So while we can physically distance, we need to make sure that the socialization is still there, whether it's through Zoom, meeting someone for a walk. Even if you just go for a walk by yourself and just, you know, smile at the person walking to the side of you, make sure that you keep those connections. And then practice self-compassion. You know, if we don't care about ourselves, we can't then begin to care about others. And we also have to think about, so we have to be a bit selfish, think about ourselves first, and then start to think about other people. Sorry about that. Sorry about that.
It happens to
Mute
us
the
all,
phone.
Roxane.
Okay, phew, last slide, sorry. I'll get there eventually. So, okay, in terms of well-being at work, why is there such a focus? As Neil has said, as Reema and Chris have said, why do we want to get back people into the work environment? Because we need to work as humans, as individuals, as people, regardless of who we are, what we do. Work is good for us. It actually helps to keep us healthier. It maintains our well-being. When we work at jobs we enjoy, that actually helps us to grow, helps us to develop, helps us to actually interact in a healthy, calm manner. It improves our health and coping mechanisms. We enjoy what we do. And there's research that has shown that work satisfaction actually influences life satisfaction. You know, so it can actually help us to live a bit longer. And anecdotally, I know that one of my first jobs, and when we had all these senior high-pressured people, as soon as they retired, usually they got heart attack, they fell with some illness. Oh, I'm sorry about that. So, you know, because it was so high-pressured that they didn't really allow themselves to actually come down from the job. So I think, you know, we have to think about, we have to enjoy our work, yes. We also have to make sure that it doesn't make us ill even when we retire from it. And well-being contributes to better mental and physical health, so everything is connected. Job satisfaction has been shown to lead to improved productivity and performance. And when workers are healthy and when we actually maintain our well-being, you know, regardless of the age, and there's this myth about older workers, no, that's a myth as well. There's so many myths about older workers. So we actually benefit, the workers benefit, the organizations benefit. So that's why we've got this focus on getting people back into work and in good jobs, in healthy jobs, in safe jobs, where they're supported, protected, and are able to function effectively. And that is me, that's my Twitter handle. So I've now started to tweet. So if everyone wants to tweet at me, that's fine, you know. Nothing that gets me into trouble, unfortunately. So any questions, let me know, please.
Thank you, Roxane. That was really interesting. We'll have a few questions devoted to Roxane. So she's had the same opportunities that the other two speakers did. And then we'll open it up for a group panel. It would be really nice to be able to see people's faces. So can you put your video on if it's not on already? There was a question a second ago from Patricia, which was a question to Roxane, but also to Chris. And I'll read it to you. Training features prominently in the discussion. What evidence is available to suggest that training content outside of the HSE standards, especially as anecdotal evidence, suggests that globalization has contributed to diversity in the workplace? And then finally, what is your view on cultural competence training as unconscious bias? Training as unconscious bias training has been seen not to be affected. So I'll just break that down because it's quite a big chunk, Roxane. Training features prominently in the discussion. What evidence is available to suggest training content which doesn't cover the HSE standards is available, especially as anecdotal evidence suggests that globalization has contributed to diversity in the workplace? So that's to you, Roxane, in the first instance, and then maybe Chris would want to add to that.
Yeah, thanks for that question, Patricia. Now, the HSE standards is actually based on many models that had already been proven to work. So the HSE standards did not arise as an independent piece of work, but it's actually based on many other models that had worked in the past. The HSE standard, including because there's tons of research around demand, control, support, role, and relationships in managing mental ill health. The HSE standard added the change aspect of it, which had been considered, but not had been considered as extensively as before. So it's actually based on a robust set of models that have actually shown these are the issues that impact on individuals within the work environment to make them become ill. And in terms of global, I think I'm trying to understand what you're asking, Patricia, in that any questionnaire, because an outside, if we develop a questionnaire, we have to look at the reliability of the questionnaire, which means that anyone who's taking the questionnaire will be able to understand it the same way. That's why we have to do all the psychometric tests on it. And also there have been many countries that have actually translated and retranslated. So you've got the back and front translation to make sure that when it's being administered in a country that's French speaking, Italian speaking, Spanish speaking, Russian speaking, you know, Chinese, whether it's Mandarin or Cantonese, that they actually understand it the same way as someone would understand it in an English speaking country. So I think that's what you're getting at, more or less. I think so. And in terms of cultural competency training, as well, the evidence is showing that unconscious bias training does not work because it's basically a tick box exercise. So my preference is for conscious bias training to let people become aware of how their behaviors are acting and influencing someone else, and to make them more anti-racist rather than acknowledge the racism and say, well, this is what is happening. What do you need to do differently? So unconscious bias training does not work. So it does not make anyone become less racist, less discriminatory. So I think that's my take on it. And it's not really a cultural competence training because it just gives, I mean, I had to do one when I was in my last organization. And at the end of it, I thought, well, what was I supposed to learn from that? Because it didn't really address any of the issues that are actually discriminatory in the workplace. So I think we have to think beyond trying to change someone's bias, but rather make them see why their bias is occurring. So I don't know if Chris wants to add anything.
Can I add something before I bring Chris in? I think the other thing, Roxane, about unconscious bias is that if you understand why you think in the way that you do, then you can do something within the organisation to improve their policies and procedures. And I think that's so important that employees have a full understanding of how they think and act might impact on somebody either from a different culture or somebody who has got a disability. And mental health is a big issue there because unlike physical health, where people are prepared to talk about it, and they'll talk about having had their varicose veins stripped or they've just had their appendix removed, but they won't talk about their mental well-being because there's this big stigma, and that's something that I feel strongly that organisations should grapple with.
Yeah, I agree with you. And it's not just having the policies in place, it's make sure that they're implemented and they're implemented fairly. So make sure that when someone does something that's racist, that's discriminatory,
or discriminatory on other grounds,
they are made to realize that this cannot happen within the work environment.
Yeah, thank you. Chris, sorry, I cut you off in your prime.
No, thank you, Anne. So for us at the moment, with us specifically as IPS services, topical at this moment, well, I attend as a service manager at the Community of Practice for London for the IPS, and at the moment across Northwest London IPS services, there's an health equality evaluation happening, and that is recording, you know, from the perspective of clinicians and staff who work in the IPS field, and more particularly the people who use the service, just to have an overall, a broader view of what is the actual outcomes for people that we are helping, people from ethnicity, Black and Asian minority ethnic groups, and are they getting the job outcomes? Is there equality of outcomes, not just equal opportunities? So this survey is actually happening at the moment, so it'd be interesting to see what the outcome is from it, and that's an interesting question that we're asking here. And there are things in our field where employers, there's like a tick box employers I don't know if people know about mindful employers who are positive about mental health. So they positively accept people with mental health difficulties. So some employers are signed up to that charter to then give that kind of equality to people who have mental health disability or mental health difficulty. So along the lines where of this question, if there were more employers signed up to this kind of charter, then that might be some road or inroads into ameliorating or improving the situation of discrimination, particularly against mental health disability, but also in a broader aspect, as Roxane has touched on, in terms of discrimination, sexism, racism, right across the board. So unconscious bias training, in light of the recent Black Lives Matter movement in the United States of America, there's something else within the community practice of IPS where, shall I say, our service in Hammersmith and Fulham, West London, we're going to have a fidelity review based on the IPS presentation we just had today. So there's that 25 elements on a fidelity scale, which we just explained to you. But part of that inspection will not just be talking to clinicians and people who use the service and the staff, it will also be around racial equality, as I've just mentioned. So it's something, as I said, following Black Lives Matters, that it's become part of the heightened awareness in actually how are we being diverse in our workforces, in our practices, in the people that we help and in our own staff. So that's actually embedded now within the actual IPS fidelity review. So again, it'd be interesting to see the outcome of that, which we are going to have that in February. So those are my observations about the questions of unconscious bias training and the diversity element.
Thank you. I've got a question here about how to manage a return to work where the person that's the problem is the manager. So the manager isn't supportive, isn't aware of mental health issues, and they're the one that is causing the stress. So how would you manage a return to work under those circumstances? So that's primarily for Roxane, but also for anybody else that would like to contribute.
Yeah, I mean, that can be an issue. So I think it's, again, we're going back to psychological safety. Is the organization open enough to have those conversations happening? So, you know, can you raise it with someone else, probably someone senior within the organization? It might be you might want to have a conversation with your line manager if the person is open to having that conversation. But if the person is not, hopefully you can go somewhere else in the organization to raise this and say, can I get some support in managing this, please? But it always is tricky. And the research shows that line managers, you know, can be one of the major issues with ill health within the work environment. So hopefully the person can raise it somewhere else to get that support in managing that difficult situation. I don't know what Chris or Reema, how you deal with that in actually getting people with mental health conditions back who would have those challenges of actually saying, this is harming me more than it's, you know, helping me. So.
Yeah, I don't know if Reema has some examples from her caseload, but there are cases which I'm involved with other members of our team, and there are issues around. It's just, I mean, it's a rapport breakdown, it's a relationship breakdown, and it can be with a manager, and then that can be something of an impasse for the situation. But definitely that's an occupational health issue, that's a human resource issue. So hopefully the broader HR department, the HR section of an organization can get involved in that and avoid grievance procedures and avoid, you know, it's always about, can we do things informally first? Can we sort this out informally? Can we sit down, a reasonable adjustment thing? Can we talk about what does this person need? Is there an acknowledgement, or is there an understanding around mental health within that particular organization that goes beyond, you know, because people can have personality clashes, that can happen anyway. but is there a broader foundation within the organisation that supports if people who have that mental health difficulty and have that understanding that the person's having problems at work, and it doesn't just become personalised, and it doesn't just become polarised debate about two people, if it is the manager who is the problem. And again, as we mentioned in our presentation, around the Disclosure and the Equality Act, that speaks straight to that, about the equality that a person is having by law, that the person can't be discriminated against. And again, but it's a tricky situation, because had the person disclosed before, which it doesn't always happen, so then the employer sees the person acting in a different way, and then they don't, then say, why is the person acting like that? They don't actually know the person has a mental health difficulty. So it can be a bit tricky. And that, again, that discussion about disclosure with the employment advisor, just saying, well, these are the instances where it would be a pro, rather than a con, because then it will help you if you have a mental health difficulty, for them that be openly known about. But yeah, so in short, if the whole organization has that, it's right embedded throughout an organization that there is other places you can go to help within that organization, it makes it a lot easier.
Would you recommend that one of their options is to go and discuss it with their HR department, or even their trade union representative?
Yeah, and that's one of the first questions that I asked as a person represented by a union member. Sometimes, unfortunately, where people aren't, they can get treated shoddily. I've just been talking to one of the lead psychologists here, as an instance that's happening at the moment, and where somebody is not necessarily being treated well by the employer, or the employer is not receptive to that. And we're talking about getting the HR team involved, because in the first instance, it seems like they're not taking the person's concern seriously. And then that could easily be dismissed. And if the person doesn't know their rights, and if they weren't connected to us, and they didn't have any representation, and they become unwell, then they could easily just lose their employment. So definitely we need to look at getting the HR teams involved, because then it's a matter of the legality, and that would then definitely go to a tribunal if everything is laid out on the table.
Thank you.
Can I just come in? From my point of view, I mean, I agree, all extremely sensible suggestions. I think from the clinician viewpoint, if you're at the point that someone's going to go back and they're telling you, that their boss is the problem, which may or may not be the case, you never know yourself as the clinician. What you can do is try and arrange a case conference for going back, and with obviously the patient's permission, to share relevant functional details at that case conference, because then it sets out very clearly that this isn't the patient or the clients for coming and telling their boss, you can't make me do this. That actually this is the clinical view. And by all means, when people from HR could come along, and actually, I think if that sets out very clearly and is documented about, what is a reasonable adjustment, what can happen, that could set people off on the right footing. I think where it quite often goes wrong is it doesn't have that sort of set off on the right footing. It then goes downhill a bit, and then by the time that you get involved again, it's the relationships have been soured and things. So yes, absolutely, unions and tribunals and everything. Sadly, people do get there. But if you can set off the return to work on a management plan which is functionally based, with backed up with clinical information, and you go off on the right footing, hopefully even a manager who wasn't reasonable would sort of see that actually they have to go down that path, or otherwise they're going to get into difficulty.
And also what came up in the case today is also like the fitness to work things, and the forms you can get from a GP, and going through the right steps as well to back up the person's mental state at that time. So all these things, adding to what Neil's saying, all those things happen if the process is done in the right order. It does help a lot.
Thank you. I'm going to go down the questions that are in the chat box in the order that I can see them. So I hope I don't miss anybody's question off. But there's a question here from Dr. Frances Klemperay, to the whole panel. She gets asked by patients 2 questions. First of all, what do I put on the application form when asked if I have ever had a mental health problem? Can't see where the other question is, but anyway, how would you advise one of your clients with regards to them indicating on the application form for a new post information regarding previous or current mental health problems. So I'll direct that initially to Neil, please.
Okay, I'll be very interested to hear what Chris and Reema have got to say about this. But my view, actually, and the second question was, what would you tell your boss or your manager when you went back back to work?
You're psychic.
That's okay, because I wish I was. It would be great. I think that you have to start off by thinking that we're in a country where there are legal protections and people have to treat you reasonably, and therefore you should be a reasonable person and put down limited information that's functionally relevant about, I had a mental health problem. You can call it depression and anxiety disorder, whatever it might be. And, this happened in 2017. I was off work for 4 months. I got treated and I've been back at work, fully functional for the last 18 months or whatever I think that you should write that down and you should be honest. And I think obviously the Equality Act may well come in to protect you if it's a longer term condition, but I don't think you should get yourself in a situation where you don't declare, because I think that makes it very difficult. Although I fully accept that can appear to be quite frightening, particularly so I have to say with the military who have who aren't covered by the Equality Act, and there are some standards which you can find if you're interested in the military online. I think in terms of what you tell your boss, I think that if you don't give your boss sufficient information, it's hard for your boss to help you. So I think you should go back and you can say I had some psychological difficulties, or my mind was all over the place, or whatever I sought some help. You can find your words, but I think you should also say, and I really want to get back to work. I'm motivated, and can we possibly suggest some things that we can try and put in place temporarily to try and make it easier for me to get back into work? So to try and throw down the gauntlet, so to speak, to say I want to be back, I'm here, but I might need some temporary help. And you'd hope again that if it's a reasonable boss, that would again start off a conversation with well, gosh, how can we help? So that's my view. Thank you,
Chris and Reema. Would you like to add to that?
Yeah, I'd say definitely adding to what Neil's just said there. I think that's interesting because it's the exemption around the employer as well. Some employers may be exempt around that, and people do need to demonstrate some mental health fitness to actually be in that employment. But what we tend to have a stance in our service where, again, it's around what do you feel you want to do. You don't feel pressured into writing anything in a form that you don't want to write. And at what stage do you declare that within your employer? And especially in the stage of application, you haven't been offered any terms of employment. You have not. You haven't been offered any terms of employment. If you're applying for a job, you don't know whether you're going to get it or not. So there may be another phase or stage in the application process where you could then declare that if you wanted to declare it, if you felt that was the right thing for yourself to do. I don't know, Reema, if you have any kind of recall on any cases around this kind of topic.
No, yeah, I kind of support what you're saying as well. Thinking at the application form stage, some of the questions are usually like, do you have a disability that impairs your day-to-day kind of functioning? And some clients don't view it as a disability, or they don't think they have an impairment on their day-to-day functioning, so they'll select no. Some others like comfortable. I say that happens less as my client group, but they're happy to say on the application form why they've been away from work or had a period of like a job, a career gap, for instance. And then sometimes there's a lot of the time there's prefer not to say, so clients select that as well sometimes. But going with what Chris says, we don't put any pressure either way. We put emphasis on what the client feels comfortable doing.
While I've got you, another question, Reema and Chris, which has come from Janet O'Neill. Do you have any contact with the employers of your clients?
Yeah, so employer engagement is a part of the individual placement support IPS model that we have to engage with employers based on the client's preferences. So then we talk with employers as well. And also when somebody gets a job, especially in the first few weeks, first month, couple of months, somebody may be vulnerable, not everybody, but I definitely know when I've worked with people, some people have been vulnerable, settling into workplace and have been very at risk of losing a job early on. So that's where Reema's role really plays a key part in being there with the person to help them when they're early, early stages of the job. So that might mean, if needs be, liaising with the employer, or talking to the person during lunch breaks at a certain time, and they can have a call to talk to somebody. So yeah, that's embedded within the work that we do.
Thank you. I've got a question for Neil. Would you like to elaborate a bit more on PTSD in ITU staff? Because you just have to watch the news and hear the horrendous positions that ITU staff are in at the moment, that one person, they might be looking after 3 or 4 patients, one person dies, the next person dies, their next patient dies, that's all on one shift. And that must be extremely traumatizing for the doctors and nurses working in that environment.
Yeah, so we actually published a paper, as I said, in Occupational Medicine on Wednesday this week. It came out. So that was data. So myself and Professor Kevin Fong from UCL have been working. So we've done 5 pulse surveys in intensive care staff, which started in June and July, which is what the paper was on. But we've also done ones in September, end of October, and end of November, beginning of December. We're just about to do another one. So we've been monitoring, and we've got, now we've got a few thousand staff in that group. We think we've got somewhere between 1/4 and 1/3 of each of the units ICU staff. So although there's a potential for some response bias, actually we think it's probably pretty good. But we're using brief self-report questionnaires, perfectly validated, but they're brief self-report one. So we can't make clinical diagnoses. But certainly in June and July last year, we found that probably in the region of 40% of staff working in ICU were reporting symptoms suggestive of PTSD. Now, we don't for a moment think that 40% of them have got a clinical diagnosis of PTSD, but we're pretty sure, even when we adjust our thresholds on the surveys very high, it's going to be 10, 15%, which is sort of 2 to 3 times, if not more, than you would find the general population. So we know that absolutely these staff are at risk. We think that actually moral injury, just as you said, Anne, the fact that, I want to deliver the best care, but actually it wasn't good enough. I've got 3 patients. I can't be in all 3 places at the same time. And you've also got staff on intensive care who are not intensive care specialists, who are doing simple tasks, but they get put in these incredibly difficult positions. So we think that is making an impact. What we don't know yet is what the impact is of the things that have been done to support staff. So there has been that REACT training I mentioned, that has gone into ITUs, and there's more of that going in. There has been lots of staff support options and peer support. So as yet, we don't know what the mitigation is, and what we're going to do next is do a calibration study to actually work out what proportion of those who appear to have PTSD really have. But the 2 main factors of this is, one is functionality at the moment. We know that PTSD symptoms impair people's ability to function well. So probably the care delivered is going to be impaired by the fact that staff have mental health symptoms. That's one thing that's important for obviously patient delivery. But the real thing is that as hopefully we begin to recover, then actually people are going to start needing treatment. And I think the difficulty is, asking people to wait the standard amount of time is going to be very difficult. The plan is, I spoke again to the NHS this morning, I'm part of their sort of recovery commission, it's called. The plan is to have these things called wellbeing hubs in place, which is there's 15 million of resource which has been split up around the NHS to develop these teams which will be able to do outreach, assessment, and to fast track people to specific services to provide treatment. Now, the NHS are being a bit cagey about what treatment means, but the idea is that they shouldn't necessarily have to go on a standard, go and see a GP and wait lots of months. So in theory, if it works out as it says, as recovery of the NHS occurs, we should be recovering our people before we recover our services. That's the key thing, because people are going to need some time off. But yeah, it is a real issue, and it's an issue in terms of ability to function, as well as it is about the moral duty to look after them.
And if we don't recover our people, we won't have any staff to help recover the services. So it's a difficult conundrum.
It is exactly that. No, so this is getting a bit kind of political here, but I kind of, so with the military, there's something called the military covenant. And the military covenant says that no military veteran should be disadvantaged as a result of what they've done on behalf of their country. So if they happen to have a mental health disorder caused by service, then there is a specialist veterans mental health service they can go to. They get priority more better than you get if you're not a veteran. Well, the NHS have given their all over the last year. They've saved lives. They've gone above and beyond. They've suffered psychological injuries. They've been threats themselves. There is no reason at all, if we're doing that for veterans, that we should not do that for NHS staff. And I don't know whether it will happen, but that certainly seems to be the case. At the moment, the NHS are not allowed to give priority care because it's not legal, so I'm told. So it's this crazy situation that they're not. But so that's kind of my view.
But it's interesting and gratifying to know that you were involved in the Nightingale hospitals because of the PTSD element.
Yeah, so I was that was last year. I mean, the Nightingales now, they are being used a bit, but thankfully they're not mostly being used for COVID patients. The ICU units are doing their best to do an amazing job.
Thank you. I'm going to ask another question here to the panel. So whoever feels best positioned to answer it, what's your view on cultural competence training? Who'd like to take that one? Nobody.
I guess I'm not entirely. Oh, sorry. Go ahead. Go ahead.
Yeah, no, I'm not so sure what cultural competence training is. What exactly?
That's what I was going to say. I was going to say the same thing, Roxane. I'm not sure what the question means.
Yeah.
Could the person who raised it unmute themselves and ask the question in a way that the panel can answer it, please? Because I don't know. I just have the message. Maybe it's somebody that's rung off.
Patricia's hand is raised. I can see it.
Patricia.
Yeah.
Patricia, was that your question?
Yes, it is. Hello.
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 Hi. Obviously, the pandemic had actually showed a lot about health inequalities. Like Chris pointed out, not just the health inequalities, but the issues around equity. Surprisingly, Society of Occupational Medicine document on management of vulnerable people on COVID did mention cultural competency. We do know very well that the workplace is so diverse now. Managers may be speaking to an employee who obviously has some mental health issue, particularly depending on if they are from the ethnic minority. Cultural differences, some of them are nurtured, So a staff might not be able to, it's not necessarily that the staff doesn't want to make eye contact, but has some cultural inhibition. Mm-hmm. I'm using that as an example. So that can be misinterpreted by the manager in evaluating situation at that point, which when we talk about communication, we talk about taking nonverbal cues. So how much more if Society for Occupational Medicine recognize cultural competency, which is actually much more practiced in United Kingdom, what role will training do if unconscious bias has been recognized as ineffective?
I don't know if Chris or Reema want to pick up on that, but I mean, under the Equality Act, you can't really discriminate based on differences. So I'm thinking especially in terms of occupational safety and health, you have to make sure that if someone comes in whose first language is not English, you have to make sure that you find a way to actually make sure they understand what's required of them, how to interact. Otherwise, you're discriminating against them. So I don't know if Chris or Reema want to pick that up.
Thanks, Roxane. I think, how it stands is you don't have to treat everybody the same. You just have to treat everybody equally. And based, as Roxane said, based on what that person's needs are. So in terms of the cultural competency, it depends on that, the breadth of that manager or that organization's knowledge around different ethnicities, probably in different parts of the country, different parts of any particular area or city or region. There might not be a particular, there might be person who's more in a minority in that area, shall I say, and the organisation they're working for may not have those cultural competencies, as has just been mentioned, or not be aware of them and not know them. So it might be unknowingly that, you know, that they don't know what to do with this person, don't understand the person, as you say, whether it's eye contact. People don't, in some cultures, people don't look people in the eye as a matter of respect, not that they're not listening. So long as that employer gives that understanding, that leeway for that. But I get what you're saying. How then, that is a good question. How then do you, because a lot of these things we're talking about, they're written as good ways of behavior, but actually how do we then put that into organizations? I don't know if I have the answer to that question. That happens everywhere. I don't know that, you know, some places may be better than others. Let's be quite honest about that. I don't know, Reema, if you have any view on that, or
no, you've articulated it perfectly.
Yeah. We literally have only 2 minutes left, so I'm going to get answers to as many questions as I can. So if I don't ask your question, apologies, I'm just going down the list. A question here from Ankush Singhal to everyone. What do you do when a person is not motivated to return and you suspect that this is sometimes due to financial conflict involved, things like compensation, insurance, claims, etc. obviously can't be proven. Dysfunction is much more than expected, and we're asked to comment on a prognosis. So, Reema, would you mind answering that, please?
I think if clients are, for instance, with benefits, if clients are already claiming benefits and things, a way to ease it in is just doing sort of part-time work. So that way their benefits aren't affected and they're still sort of kind of getting a taster of working life and things like that. Like at the point of referral for IPS, clients are usually ready to search for work and ready to be in work anyway, but that's a way of doing it. A lot of clients look for part-time work first, so they're still receiving their benefits at the same time.
Thank you. Roxane, were you going to add, or is it Neil? Neil?
Yeah, I was just going to say that I think one of the things here is that from an occupational health or occupational psychiatry point of view is about having good liaison with the treating clinicians. Now, obviously, you need patient's permission, but I think what you need to do is, if you think that there's other motivating factors going on, then all you can do, I think, from a clinician point of view, is be as clear as you can about the clinical context here. And I think that if you put that the prognosis, you know, is poor because the mental health problem is not going to get better, for instance, because, you know, they dislike their boss and they tell you that, and there's no way they can go back, and the organisation said they won't move them, the prognosis is clearly not good. You know, you might think that that's the wrong outcome, but there's no point in trying to force someone to go back into a situation where you absolutely know it's not going to work. Clearly, the best thing is to have a management plan or case discussion to try and find an alternative solution that could work. But just trying to force someone to go back into a situation, I've seen it time and time again, that, you know, it doesn't work. Everyone kind of knew it wasn't going to work, but they kind of felt that you have to give it a go because you're not going to let this person get one over on us. And, you know, I don't think that's helpful for the person or the organisation.
Thank you. I'm just going to give some comments here, and then we're going to have to wrap up because it's, according to my watch, it's 4 o'clock. A comment from Claire. Many line managers have been promoted into positions that don't have the people skills required for that post, and people managers are such an important thread in mental health in the workplace. Totally agree with that. Many managers have not had effective training to be effective managers. They just happen to have fallen into that job because they were their past experience, or they were the assistants in the past. So I think that's a very important point that she's raised. Vince Lungley of Essex Fire responded to that by saying use grandparent manager or a neutral manager to support them, and fully agreed around case management, case conference discussions, including occupational health. Okay, I'm going to wind up now because it's bang on 4 o'clock. But before we go, I'd just like to thank everybody for joining. Would you mind writing before we sign off, if there's anybody from overseas, which countries you are working in? It'd be really interesting for me to see what our reach is. I'd like to thank the panelists, Neil, Reema, Chris and Roxane for coming and giving their presentations, which are really interesting and supportive. But I'd also like to thank all you as members of the webinar for your thoughtful and insightful questions, and just to be part of learning more about mental health in the workplace. So thank you very much. I'm looking forward to seeing which countries we've got represented, and just leaves me now to wish you a good weekend and able to relax, switch off in order to go back to work next week. Thank you very much.
Thanks,
And
everyone.
goodbye.